gun violence has been thought of as either a policy fight or as a criminal justice problem, and that has stopped us from looking at the risk and protective factors for health outcomes and then creating interventions that might mediate or moderate those health outcomes more effectively than the honestly failed approach that we've been taking.
Welcome to The Other 80. I'm Claudia Williams. A quick aside, if you've been listening to the podcast and would like to keep up with news in our space, add yourself to our newsletter mailing list. You can subscribe at www.theother80.com. Systems thinkers look at a complex system and see interconnectedness. They see the interdependencies. They see things holistically. I often say public health leaders are the original systems thinkers. And boy, did Megan Ranney prove my theory. Megan is an emergency physician and gun violence researcher. She's been instrumental in shifting the national dialogue on gun violence so that we can address it as a public health issue, moving from law and order to harm reduction and prevention. As the dean of the Yale School of Public Health, she is applying the same systems thinking approach to focus on the big changes we need to drive health in America. So please welcome Megan Ranney to The Other 80. Hi, Megan. It's so wonderful to have you on the show.
It's a privilege and an honor to be here, Claudia.
I've been your groupie going to all the sessions that you're in here at Aspen Ideas Health, and somebody paid you a huge compliment on stage yesterday, calling you a master communicator. And I was thinking about it because I think that can mean many different things. That can mean storytelling, distilling information that's very complex into simpler forms, deep listening, and other things. What does being a great public health communicator look like, and how have you developed that skill?
Oh, this is a fun question. I think for me, being a great public health communicator means being able to translate scientific concepts into actionable insights for individuals, for families, for communities, and for leaders. That translates into public health and public health science because we do the same thing. We're creating scientific discoveries. We are elucidating mechanisms of disease or spread of disease, whether infectious or non-infectious. We're creating insights about how policy changes can impact whole community health. And again, the language that we use in public health, like the language that doctors use, is not necessarily layperson language. So I try to put that same hat on. If I were sitting at the bedside, if I were talking to my mom or my husband or my kids, how would I explain this? And I think that's probably part of how I've developed it, but it was never an intentional path for me. It's a little bit of luck.
I've been thinking in the last 24 hours about empathy because of the amazing session last night on AI. And one of the things that was discussed, which I found astonishing, was this idea that people don't disclose health information unless they feel emotional alignment. And also thinking about Ashoka's finding that empathy is the root of entrepreneurship. And so I'm curious how that plays into your thoughts about communication.
I think empathy is at the root of communication as well as at the root of good science, which ideally go hand in hand. You need to come to a problem with an understanding of the person or the community with whom you are working to solve that problem. And you need to communicate in a way that is both able to be trusted, but again, able to be acted on by that individual or that community. In order to use the right words, to use the right terms, to translate things appropriately, that requires empathy. It's also why not everyone is the right communicator for all communities. Because although I may have sympathy, I may not have empathy, I may not know those right terms, I may not understand the culturally relevant analogies or metaphors or the drivers, the motivators of a community. ideally, the communicator knows that. And that to me is where empathy comes in. And I think it behooves us as scientists to make sure that the work that we are doing is grounded in the lived experience of the people who are having the problems that we are trying to investigate. Because otherwise, we're going to come up with answers that are either wrong or useless if we don't have that baseline empathy. We're also, of course, going to have trouble enrolling folks in the importance of the research, contributing their data, participating in whatever form we want them to, if they don't feel that empathy, that commitment to understanding lived experience from us.
I noticed in your bio that you and I are both returned Peace Corps volunteers. I was in Botswana, you were in Cote d'Ivoire, and you've talked about how that experience of getting to know your community and really being a part of it. And you were later, I think, than I was, watching HIV sweep across the country and affect so many people's lives in an environment where, while the drugs were available in the US, they weren't yet available to your friends and colleagues. And you've talked about how that really inspired your direction in medicine and public health. It wasn't a field you planned to go into. Take us back to that moment. What really captured your heart and spirit in that time?
Oh, gosh. Thank you. And I love being with fellow RPCVs. I think we generally have a unique perspective on the world and a true commitment to community, thanks to our experience, and probably greater empathy, too, because of that sense of being different. Being the only American in my village was just a tremendous growth experience for me. It also gave me tremendous humility around the work that we do. But if I go back to that period, which was late 90s, I went into the Peace Corps, not really sure what I was going to do with my life. I thought I might do journalism or become a foreign aid worker. I actually didn't know that public health was a thing at that point. Somehow I got my way through undergrad as a history of science major and had never really heard the term public health. I thought a lot about healthcare, but not public health. So went into Peace Corps, partly to figure things out, but also because I wanted to have an experience outside of 20 straight years of being in the school system, and landed in my village ostensibly as a water and sanitation volunteer. We can talk about all the problems with the fact that I was put in this village as a water and sanitation volunteer with no training in engineering or sanitation. A lot of hubris in that placement. But I got there and relatively quickly identified that water and sanitation was not actually the top priority of my village. And as I made friends with particularly the women in the village, began to viscerally feel the impact of the growing HIV/AIDS epidemic on the women and girls in that village. We saw tremendous spread of HIV amongst women and girls, largely through their husbands or through forced sexual encounters, largely because of lack of economic empowerment. I watched friend after friend, both women and men, die of AIDS, often without disclosing what they had. They would say it was hepatitis, it was diarrheal disease, they would come up with anything because AIDS was such a horrific disease. There was such stigma around it because there were no treatment options. And then because no one was saying, this is HIV, this is AIDS, of course, it would continue to spread because if you couldn't talk about the disease, you couldn't talk about prevention measures. So I started to work to try to get friends into treatment programs down in Abidjan. The World Health Organization was doing some early trials of antiretrovirals in Africa, right? At that point, there was this conception that somehow Africans were not going to be compliant with the meds and therefore would cause viral resistance, which we know is baloney. So the only place they were doing these trials was in Abidjan, and you had to be actually physically present. And so I couldn't get my friends into the studies because they couldn't travel down there. They couldn't afford to live down there. We were 6+ hours north of Abidjan. And that changed my trajectory because first, I wanted to be able to provide that treatment. I wanted to relieve that inequity. I, of course, wanted to work on the economic empowerment and the structural conditions, which I now know is public health. I also wanted to be able to prescribe. I wanted to have the authority to say, I'm going to bring these medications out into the countryside and make them available so that then we can destigmatize the disease and start doing the education and the prevention. My uncle had been a member of ACT UP in LA in the 80s. So I knew the difference that access to antiretrovirals makes for a community. And so that drove me into medicine. But then I kept with me this commitment to this thing that I didn't yet know was public health, which was also, how do we change the structure in which these decisions about provision of medication and testing get made?
It's a wonderful story. And I think while I left before HIV/AIDS had really hit Botswana was very heavily affected. The same dynamics were in play there. And I know one of the things that happened in that same stigmatized environment is that younger and younger girls were engaging in sex because they were perceived as clean. And so you have this horrible negative dynamic where it's affecting younger and younger people.
A, because they were perceived as clean. B, because it was the only way to pay for their school uniforms and their school books.
Yes.
There was this term, they called it blue and white prostitution, because the schoolgirls wore these blue and white checked pinafores to school. And the families didn't have enough money to send all of their kids to secondary school. So girls would be able to go to secondary school by sleeping with older men.
I was a teacher.
Yeah.
And I didn't know about public health. The reason I learned about it was I was starting to do some qualitative research on why were so many of my students, girls, dropping out pregnant when there was such wide availability of contraception, at least the perception was. Had conversations with these girls about those very same things. And when I asked the people that were running the study, like, what training do you have? They said public health. So very interesting connection on those. Like, for me, what was interesting is how do we get to the underlying dynamics that are creating this horrible situation for people? One of my recent guests was Ann Zink, and I know you and she share a lot. You're friends. You're also both emergency department doctors, physicians, and you're public health leaders. And both of you have called for a rethinking of the relationship between medicine, clinical care, and public health. And that was something you talked about on stage yesterday here at Aspen. I think you were one of the people that said, like, this makes so much sense, but what does it really mean? And I think all of us had a front row seat to the divides between public health and medicine during the early stages of COVID. There was progress towards rethinking that we're now retreating from as we go back to a little bit more of our normal lives. I'd love to have you paint a picture for A, what the issue is, and B, what are some of the strategies or solutions that we can start to put forward?
Well, I'll start by saying, for those who have not yet listened to it, your podcast episode with Ann Zink was just outstanding.
Oh, thank you.
And so I will try to not repeat things that she said, although we do share a lot of the same perspectives and hopes for the future. So the session that you were at yesterday was one with the Common Health Coalition, which was started by Dave Chokshi with partnership with a number of healthcare and public health organizations across the country, with this idea of creating mechanisms for public health and healthcare to work together, as well as incentives and exemplars of how we can do that. It's almost crazy that we don't work together. To those who are not in our field, they would find it incomprehensible. But the reality is that whether it is around data sharing, whether it is around data analysis, whether it's around communication, prioritization of what the biggest problems are, or advocacy, again, for that structural change for addressing the other 80% of the drivers of poor health, we don't join together. And I think it's for a few reasons. I think the first is that we are not trained together. We don't have the same language. We don't necessarily think about problems in the same way. Thinking about problems in different ways is, in general, a really good thing. But when you have healthcare that's thinking about individual level patient interactions and about meeting their bottom line, right? Those are their two big things. We want to provide good quality care to individual patients, and we also need to make sure that we're financially sustainable. And then you have public health, which is let's measure it, let's set up these big community level programs. I think there are problems with data privacy and data use agreements and data governance that prevent us from collaborating. And I think there are problems with the funding structure that keep us from collaborating. Again, how a healthcare system makes their money is very different from the revenue streams for public health, whether government or community-based. And finally, I think we haven't done a great job of showing how in collaborating, we can help meet each of our goals. To reframe it, right? What is the alternative? When you get into the brass tacks of what that looks like, it of course is about shared data systems so that we can respond quickly and effectively to emerging or chronic outbreaks, whether it's chronic disease, injury, or infectious disease. It's about having shared goals, and it is about creating some shared funding streams. As Anne will talk about a lot, the 1115 waivers, the work that Medicaid and Medicare are doing around social determinants of health are great. I also think we have to create some flexibility for the public health workforce side of the house in terms of what those funding streams look like. And we have to get the non-government, non-healthcare folks involved, private industry, school systems, community-based organizations, also have a seat at the table in the public health infrastructure and can contribute data, can help decide what problems we're going to address, and then can help create shared solutions to move us forward.
I've been thinking a lot about this because in California, Medicaid is now requiring its Medicaid health plans to come up with community health assessments that are joint with public health and with hospitals. But it feels like there's such an opportunity to actually start to articulate the distinct roles and the handoffs to tackle some of those issues across those different entities. And I love the fact that just even requiring a joint conversation is an intervention itself.
And not duplicating ourselves. If we go back to the empathy part, if I'm a community member and I have the hospital system coming to me and then the public health system or a nonprofit coming and asking the exact same questions that I've just answered for someone else, that feels like you don't understand my life. Because why would I spend the time to go through this community health assessment for two separate organizations that are both working in the same town? We should be coming together to help make it easier for folks to do the work that help to keep communities healthy. And so that new mandate, I think, is outstanding. And then this is where academia can step in, is to help create the methods, maybe some contracted or volunteer workforce to help get that done and translate it into action steps effectively.
I've had the sort of dream that now you're inspiring me to work on, which is, wouldn't this be an amazing opportunity for MPH students to go out into their own communities and help figure out not just, again, what those issues are, but really how might people work together in different ways, and to hear directly from citizens, not just through their mediators, the CBOs and things like that.
And I love that for public health students, because I think one of the things that we really need to lean into, and of course, our accrediting body requires this, but it's done differently at different schools of public health, is to have those real practice-based experiences directly with the populations who we are working with and on behalf of. I think it's really easy when we are not in a clinical setting to take that kind of ivory tower or 10,000-foot view and to forget about that lived experience of the people that we're working with. And so whether we are working with healthcare organizations, with community-based organizations, with schools, finding a space where, particularly for students, they can be on the ground will make a world of difference for long-term success and for understanding of the real barriers to implementation that exist.
Love that. Let's talk more.
I look forward to it.
So you've spent a large part of your career focused on firearm violence. And we've been talking about it here at the Aspen Ideas Health event. And just to paint a little bit of a picture of what we're talking about, almost 50,000 deaths in the U.S., more than half of those deaths are suicides. And that affects every single community, every single neighborhood. It's not a urban or a rural issue. It really cuts across. And you've really called for a reframing of the discussion and the debate into viewing this issue and its solutions in a public health frame. So I'd love to have you talk about what that looks like first, and then let's talk about where that leads us in terms of strategies.
Thank you. Well, by thinking about firearm injury as a public health problem, it means first and foremost that we are approaching it as a health problem, that the outcome we are looking to influence are health outcomes, not criminal justice outcomes, right? But rather we're trying to decrease injury, death, as well as the health ripple effects of every shooting on the individual who shot and on the perpetrator, but also on their community, their families, bystanders, friends. We know that when there's a shooting in a community, kids' school test scores go down whether or not they were present in a witness, just because they know that there was a shooting nearby. So the first big and important thing about taking a public health approach is what those metrics are that we are trying to change, shift to something that is inherently community focused and hopefully restorative and resilient. The second thing about the public health approach, and your listeners to the podcast will know this well, but it means that we are using the science of public health, our standard 4-step approach that we apply to every health problem. We measure the problem. How common is it? Incidence, prevalence. We examine risk and protective factors. We then develop interventions that either decrease risk or increase protective factors. And we know there is a wide suite of interventions that we can use in public health, ranging from individual level interventions and education through community level programming to actual structural change to, of course, policies, right? So we develop and test those interventions across that full spectrum and see what works. And then the last step is we scale it up and then we measure again. And I've listened again to your other podcasts, and we can talk a lot about all of the ways in which we apply that, but it's not been applied to gun violence. Gun violence has been thought of as either a policy fight or as a criminal justice problem. And that has stopped us from looking at the risk and protective factors for health outcomes and then creating interventions that might mediate or moderate those health outcomes more effectively than the honestly failed approach that we've been taking.
You've often brought up the history of car crash deaths because they've gone down 70% since the 70s. I was of the generation that I had years when there were no seatbelts. In fact, my sister had some teeth knocked out because she was not wearing a seatbelt. So this is something that's really taken place in our lifetimes. It's the speed laws, it's the drunk driving enforcement, and all of those things. So take us through the different layers of that approach, because I think what's interesting is combining very mechanical things with behavior change items and then other things that are having to do with laws and regulations.
Yeah. So for car crashes, it of course started with observing that car crash deaths were at an all-time high and that we needed to do something about it. And then we started measuring where are car crash injuries and deaths happening and why. Well, they're happening because people aren't wearing seatbelts, get thrown forwards. The design of windshields means that the windshield turns into shards and they get impaled or they get thrown out of the car. It's also happening because people are driving drunk. It's also happening because people are driving on wet roads. It's also happening because people are speeding. So we start identifying those risk and protective factors. And then we started developing interventions. Some of them are mechanical. Seatbelts, especially kind of the 3-point seatbelts, change in the design of cars to have crumple zones and windshields that star instead of turning into shards of glass. It's around changing the design of roads if there are particularly dangerous intersections. It's around changing economic incentives. You go and take driver's ed and you get a bonus on your insurance as a parent for your kid, or you get speeding tickets and you see your insurance go up. So you start creating an economic incentive for safe driving. And then it's around educational programs and social norm shifting. Drunk driving. If I think back to my childhood and the number of times that you would see movies or TV shows where someone would take a drink and then get behind the wheel, it would happen regularly. Now, the only time you see that in the movies is if they're about to go get in a crash. Right? And so we've changed the normative expectations around drinking and driving in an absolute sea change way. And we've created alternatives. So you can Uber. There are studies showing that when rideshare services were put into cities, rates of drunk driving would go down. So it's this whole suite of different interventions. Along the way, we did not demonize cars or car owners. Rather, we worked to reduce the risk of harm, saying there are some people who maybe shouldn't be driving, right? And we do need policies in place for some of these things that we know are huge risk factors. But we're going to work in collaboration to help reduce the risk of harm. 40% of households in America have a firearm. We've got to do this work, again, with empathy and in community and in a way that reduces the risk of harm for all, because nobody wants their kid or their family member to get shot. And so when we start with that as the goal, we can then reduce harm.
So I want to share a personal experience because it was something that really left me feeling very depressed and frustrated. The apartment building I lived in Oakland unfortunately saw a dramatic surge in gun violence at the beginning of COVID and then persisting after. And over the last 2 years, there have been 6 gun deaths within 2 blocks of the building. And as people in the building met with the leadership of the police department to express concern, and most of the questions had to do not with how can you police more, but what is your prevention strategy? We noted that there was no parking enforcement so that people that were parked all night could just stay there. What about economic development? What about summer programs for kids? Every single question we asked, we were told that is not our jurisdiction, and we just put in a request to the mayor for more money, so please support that, for more police officers. When we were not asking for more police, we were not asking for the things that they were offering. What are some of the things that we could have looked at that moment to understand this problem? And what are ways in which you've seen the criminal justice side work effectively with the community on these issues?
First of all, I'm so sorry for the 6 people who lost their lives and for everyone who knew them. So to start there with centering it in that kind of real human effect and the fear that you and your fellow building occupants are probably living in, and the same is true for others in your neighborhood. So I think starting with that and acknowledging that, if we channel Brene Brown, right, you have to start with the human side. You know, different police forces are different. There are some that are quite dedicated to public health, and friends of mine who are police chiefs, including Huey Clements, who was our chief of police in Providence and is now down in D.C. running their community-oriented policing program, will say that in the best of all possible worlds, police serve as officers of the peace and as facilitators of peace and safety rather than as punitive agents. And so I think, to me, I start by that type of engagement, which is we are all here because we believe that this community deserves to be safe. And I'm here as a building inhabitant who wants to work with you to think about how we can help make that happen. Because honestly, it puts the police at risk also. When there are more guns and more gun crimes, police are more likely to be shot too. So let's think about how we can try to increase safety and peace in this neighborhood. And so to me, that second step is saying, what are the things that are in your jurisdiction? And if they're not in your jurisdiction, who can we partner with? Are there boys and girls clubs or 4-H or Big Brothers, Big Sisters in the neighborhood? Could we start a community garden? What are the spaces that you as police are observing as drivers of this problem? What's your diagnosis of the risk and protective factors? And how do we work together to reduce those? And then for those spaces of overlap with the police, things like streetlights or enforcement of parking bans, what is it that's keeping you from doing that? Is it fear? Is it, right? Again, they're a workforce too. They're demoralized and understaffed. And what are the things that the community can do to help support those basic safety functions of the police in the neighborhood? And I might even also have that conversation, not just with the police leaders, but also with other community leaders who can pick up the other pieces of the mantle of that multiphasic type of intervention.
And it points to me as a citizen, I think it's a lot to put on citizens to have them be the glue that knits those things together. So for some of these big health opportunities, I think this is a great role for mayors to have a place where the different components of solutions come together and can drive that change in an integrated way. So a citizen's not knocking on all the doors themselves, but they're like, oh, that's where that's all happening.
I love that. And I think one of the challenges there for mayors, having had many conversations with small and medium town mayors over the past few years, is that we have no compendium right now of best practices, you know, like we have for cigarettes and smoking, or like we have for getting kids safely to school or for pedestrian safety, right? We know what to do to decrease the risk of pedestrians being struck. We know what to do to decrease exposure to cigarette smoke or to lead poisoning. Mayors don't currently have that knowledge base around gun violence. And I think that's partly, of course, because we had not been doing this research for so long. It's been jump-started thanks to the bipartisan Safer Communities bill, the White House Office of Gun Violence Prevention, and the work of originally a dozen researchers. We're now hundreds who get together annually and are trying to advance the science. The next step is creating those, again, that kind of toolkit Greg Jackson, who's now at the Office of Gun Violence Prevention at the White House, ran a community justice action fund before this current position. And that was one of the things that he had been working on, was what are the steps that cities can take for violence intervention that are most likely to be successful. I think it's a big space that the White House will be leaning into in coming months, and that also we as academics have a big role to play.
I love that. And I was going to actually mention a quote from Greg. He was on stage with you yesterday, and he said something that I didn't realize. He said, the idea that this is politically polarizing does not really track to the reality of what is happening in states. And I don't think he was saying that there's no political polarization on this issue, but I think he was rather saying we see evidence of change in red states and blue states. Talk a little bit about that.
I loved when he called that out, and it is so true. So first of all, most of the change that we're seeing, both around policies and around structural interventions, is happening on city and state levels right now for a wide variety of reasons. We're seeing states as test beds of new policies. Now, again, it's now on us as academics to show up and test and evaluate whether those work or not. But we're seeing new laws be put in place. Louisiana, for example, passed a law to allow someone to safely transfer firearms out of their house without fear of prosecution in a moment of crisis. You don't normally think of Louisiana as being progressive around gun policies, but this is a really important one for reducing firearm suicide. We're seeing states that are supporting safe storage laws or red flag laws that you might not think of as a typical partner in that work. And I think it comes to this kind of, again, back to that idea of empathy. It comes to this core construct, which is no one wants their kid or their family member to be at a shooting or to get shot. And whether you are a gun owner or not a gun owner, there are some core responsibilities and behaviors that we all agree on and that we want to support. We understand that people who are suicidal need to have access to mental health intervention and should not have access to a firearm in that moment of crisis. We understand that there are people who are maybe have antisocial personality disorder or are experiencing an acute crisis and should not have access to a gun because there's a higher than average risk of them shooting someone else or committing a mass shooting. We understand that there have to be early warning systems in place. So when we can create those spaces of connection, it diffuses that political tension and allows a lot of state-by-state progress.
Switching gears, you've recently taken on a new role as the Dean of the School of Public Health at Yale, which makes you one of my favorite classes of people in this whole country. I love the 4 goals you laid out, and those are, and I'm paraphrasing, inclusivity, innovation and entrepreneurship, communications, and data-driven leadership. And I'd love to have you talk a little bit about why these 4, and what does the agenda look like for a school of public health to focus on these 4 areas?
So I took the dean position because I think this is a moment where we get to reinvent how we study, teach, and most of all, practice public health, not just locally, but also globally as we come out of the COVID pandemic. And I think there's a real moral clarity, but also moral imperative for us as public health professionals to seize this moment, to take this kind of pivot point that we're at as a field and to move it forwards in a direction that we will be proud of. Because if we don't do that, others are going to do it for us, and we may not end up with the world that we all believe in. So I came into the dean position with that goal, knowing that Yale was already an extraordinary school of public health with brilliant faculty, students, and staff, and to a large extent working in kind of this classic model of public health academics, which is, we do our research, we go for tenure, we teach our students, maybe we do some practice. Of course, we all have a practice component, but not with that larger kind of statement that our goal is to create solutions to pressing health problems that can be implemented in a systemic way, right? And that's what a lot of us were doing, but we never really called it out. So when I took the job, I said, well, what are the 4 things that I think are essential for public health for the future? And it was those 4. We're now in the middle of creating our strategic plan, so they'll be shifted a bit, reflecting the feedback of our community. But the reasons for those, first, inclusion. Inclusion matters in every way in terms of diversity of gender, race, ethnicity, language, geography, socioeconomic status. But inclusion also matters in terms of making sure that all the folks that are part of the public health system who may not think of themselves as public health have a chance to be part of the solution creation. So that's maybe police or superintendents or the faith community, or, I could go on. And when I think about the great parts of public health, it's us sitting at the table with those folks that are doing the work of public health every day, but don't have a title of being public health professionals. So inclusion is about creating that space for all to understand and be part of this creation of system solutions to pressing health problems. The second one around innovation and entrepreneurship, and you and I bond over this, is this idea that, again, our work does not stop when we do the science. It's also about thinking differently about how we scale it up and scale it out, and maybe even about what those solutions might look like. So it's making sure that we have a glide path towards implementation with, of course, policy change in the public sector, community-based organizations, and philanthropy, and with the private sector, because we need to create sustainable models of public health, especially in this country that is based on capitalism. We've got to find ways to embed public health into the lives of employers and large organizations. And we have to create sustainable funding models for the work that we know matters deeply and that keeps us all physically, emotionally, socially, and economically healthy. So that's the innovation and entrepreneurship arm, and there's a lot of fun stuff there. Third is communication. We've already talked about that, but it's about teaching communication. How I learned communication in public health, in my public health training, is not how I now communicate. I learned about behavior change theory, and sure, you have to know about norms and attitudes and behaviors, but you also need to know about marketing, and you need to know about visual design, and you need to understand the information ecosystem. And those are not things we typically teach in public health. We also don't typically, in academic public health, see our job as being thought leaders or trusted messengers. And so it gets to that concept as well, about that translation of the science into terms that can be used and usable by the communities that we live, work, and play in. And then the final one, data-driven leadership. In some ways, this describes the field of public health to me. We start with data. That's the foundation of everything that we do. We analyze the data in ways that are unbiased and equitable. And then ideally, we turn it into action. We use it as something that allows us to lead. And to me, that's the ultimate metric of our success. It's a metric that I hold for myself as dean, that I hold for our school. How have we changed human lives? And that I think we need to have for ourselves as a field. It's not just about creating perfect data sets or perfect analyses. Sometimes taking 2 weeks or 2 months or 2 years to do an analysis is too much, because the problem needs action now. And we need to be skilled not just in those basic methodological techniques and skill sets, but also in their translation into things that can help change health outcomes. So those were the reasons for the 4. And I know that it mirrors a lot of what you all are doing at UC Berkeley as well. And I'm really looking forward to our strategic plan, which again has been created in partnership with community members, our faculty members, students, staff, alums. So stay tuned. That'll be coming out sometime this fall.
And one of the questions that's come up a lot in my work, and certainly in conversations with faculty, is to what extent is this focus on tackling and improving big issues around health, right? To what extent for school public health does that look like refining and honing what we're already doing, which is research and education? Or does it look like new kinds of activities and initiatives that don't neatly fall into those 2 buckets?
I think it's both and. So one example would be, I'll use kind of some of the work from gun violence as an example, because it's something near and dear to my heart. So I've been doing a study with 4-H that's funded by CDC, where we're working with 4-H to kind of change the way that we educate about firearm risk and safety, to empower both kids and instructors and their parents to recognize risk and be able to take action. We're in the midst of testing it, but should it work, we're already in conversations around how to scale and disseminate, how to help 4-H scale this nationwide, working with some school systems that are interested in implementing some training. It's not going to be me as the PI doing that, but having mechanisms for handing this off. And then 4-H has a whole system for being sustainable, right? And so they can then, they both have some grant-making capacity themselves, but also have a wide network and a way, with their affiliations with land-grant universities to do the work. So that's one example. Another example would be taking a new AI health coach tool, right? So we have lots of faculty that are thinking about how do we use AI to improve equity, cultural competence in our communication and behavior change work. How do we partner with companies to help inform their creation of programs that can go out and get insurance money or work with employers? Again, I don't need our faculty to necessarily be the ones doing that scaling, but can we have those partnerships set up where we agree with a company that this is an important goal and then figure out ways to scale it out into the real world? The last example would be working with policymakers who come to us with a problem. We help to create a solution, and then we already have the relationships with the legislators or with the executive branch who can help put that into reality.
I love those 3 examples, and they also illustrate that there's a need for kind of a middleware or a type of person that can cultivate those relationships, help seed the partnership, maintain it. I'm seeing that across many of the university settings that are really committed to impact. My friend who's at the Tobin Center at Yale, who you know, Dave Wilkinson, he talks about how I shouldn't expect my faculty to go develop relationships with all the policymakers. That's something we can do centrally. It's not a very scalable approach to expect every faculty person to understand the legislative process or the regulatory process, understand what kinds of issues are coming up in Medicaid in the state. So I'm really excited about those models. They take resources for sure, but they're exciting models.
Well, and I think that you can do it. There's all kinds of interesting things. If we think about any public health problem that we're facing, there may be business solutions. There may be policy solutions. There are almost certainly nonprofit solutions. But we can't just depend on nonprofit solutions to fill the gap in the structural problems that make us all sick.
I so look forward to continuing this conversation with you. We have a tribe of people. It's growing bigger every day that's really thinking about this question of how to make public health as a field and schools of public health the change makers that we were kind of trained to be, but maybe haven't fully inhabited that seat yet. So I'm so excited about that.
Vice versa, we have so much to do and so much to learn. And one of the things I love about being at a school is that we have unbelievable students who come with ideas that I would never have thought of. And so that is also part of the hope and the joy of being at a school of public health is this future workforce who are just transformational, helping to make it possible for them to go out and be the change.
Thanks, Megan.
Thank you.
Megan laid out a powerful framework for how schools of public health can create more impact in the world. And it's similar to the one we're applying here at the Berkeley School of Public Health. Her approach bears repeating. First, focus on 4 essentials: inclusion, innovation and entrepreneurship, communications, and data-driven leadership. Then, look for opportunities to leverage and scale the brilliant public health ideas that are embedded in studies and articles into policy change and private sector partnerships. And aren't we past due? Isn't it time to take our vast knowledge and mobilize it to drive change? This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Claus. Check out the show notes for more information on Megan Ranney and her work at Yale School of Public Health. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. You can also head to our website to subscribe to the Other 80 newsletter, which is delivered monthly and filled with resources, hot headlines, a job board, and upcoming events in health. Until next time, I'm Claudia Williams.